It's understandable that there's some misunderstanding about the difference between repeated movement testing and repeated movement as treatment. And so I'd like to shine a little bit of light on that and perhaps provide some analogies that make it more sensible to patients and to the public. Repeated movement testing is a test, and we primarily use it in orthopedics, but it can be applied to seemingly non-orthopedic complaints. A colleague of mine has a video on YouTube where he had a patient present with sinus symptoms and found through repeated movement testing that moving the neck in a specific direction repeatedly resolved the patient's sinus complaints. But primarily it's used for orthopedic complaints. And the other tests that we use in orthopedics are quick orthopedic special tests, like the Lockman test for the ACL or the Phelan test, and x-rays, MRIs, CTs, ultrasounds, so imaging tests. And for me, I place them in three distinct buckets because imaging tests, the answer is quick. Orthopedic special tests, which we learn, the dozens and dozens of them in school, they're performed very quickly and the answer is given very quickly. Does this ligament move or not? Does this reproduce your symptoms or not? Does this joint feel pinchy or painful when we move it like this or not? And then the third bucket, if those are the first two buckets of mainstream orthopedic special or orthopedic tests, the third bucket is not used very much. It's primarily used by people who have taken the effort to learn Robin McKenzie's work post-graduation, and it is repeated movement testing. And it differs from those two classifications of tests because it can be more prolonged and because it's more algorithmic, more cause and effect. The answer is not given to you in a few seconds or a few minutes. So repeated movement testing is a cause and effect analysis. And if we find that by using repeated movement testing, there is a motion, or it seems that there's a motion that when performed repeatedly will fix the disorder, we call that a derangement, a mechanical joint derangement as a diagnosis, and B, the movement that fixes the disorder is therefore the treatment. And we call that the directional preference, the movement that fixes the issue. It restores the signs and abolishes the symptoms. And so if I have a patient a neck patient, and I have the patient do repeated neck retraction, and the patient comes back and says, it didn't work, I'm not better, but they've lost rotation, for example. Well, then I've learned something from that movement. I've learned that by moving into a specific direction, I can mechanically change the presentation of this person's symptoms and signs. So I might be more inclined to think this is a mechanical problem, but retraction is not the patient's treatment. But the patient is thinking, in many cases, the treatment didn't work. But I'm thinking, well, the test gave me information and the test is revealing that no, on day one, I did not find the exact movement for you, but we will build on this information and continue the testing. It's as if a patient went to get an x-ray and came back with an x-ray and said, I'm not better. The test doesn't make you better. The test informs the diagnosis, and once you have the diagnosis, you apply the matched treatment. Another example would be someone who, say they have muscle twitches, and you want to do many things just to see if you can get rid of them. Well, that patient probably can do many things at once without having, contraindications or problems. They might increase their magnesium, potassium, sodium. They might increase vitamin B or vitamin D, or they might change a prescription medicine. And they can do all those tests, if you will, at once and see if the muscle twitches go away. But you could also think of that as treatment. So the line is blurred between what is a test and what is a treatment. Because if the patient doesn't, say they do 5 different things and the muscle twitches persist, they could either think of it as, well, I tested the theory that it was a deficiency in magnesium or deficiency in sodium, etc., and the theory was wrong, so we're moving on to a new diagnostic process, or they could conclude the treatment didn't work. And so I think there's a gray area for many things in medicine between what is actually testing and what is treatment. And in contrast to that example, where someone can do 5 or 6 or 7 things at one time, and it doesn't really matter to them how they get better, they just want to get better, they don't really care about the mechanism. For me, with movement, I can't, in this situation with repeated movement testing, I can't say, go home and do neck flexion and do neck left side bend, do neck right rotation, do neck extension, and also do some prone flexion, because they cancel each other out, or they could. And that's why directional preference is in one movement. If moving in all directions makes you better, that doesn't fit the diagnostic criteria of a joint derangement, because a joint derangement by definition is where one movement restores normal mechanics to the joint, possibly two, thereby improving motion in all directions, improving strength, improving nerve tension, abolishing symptoms. So repeated movement testing can therefore take longer. But with experience using repeated movement testing on the clinician's part, that number of tests you have to do should decrease. The more and more patterns I see with patients, the more likely I am to find or use the test on day one that becomes fruitful and therefore becomes a treatment. But sometimes it takes 3, 4, 5, 6 different tests, which maybe that person did for their muscle twitches. They did 6 different tests, they just did them all at once. I can't do lumbar flexion and lumbar extension at the same time. I will not get a clear answer because they're two opposing movements. Or I couldn't do lumbar flexion and lumbar left side glide at the same time. They're very different movements to the lumbar spine. So repeated movement testing, unlike other tests in medicine or treatment approaches, cannot be just applied all at once. It has to be methodical, because as I've said before, if that person comes back with that neck complaint, the pain is the same, but they've lost lateral movement, that informs where the testing proceeds. It's not just, oh, you're not better, try this. People do that if they buy the books and want to self-assess and self-investigate, but clinicians should be understanding how the presentation of the patient changes and letting that dictate where to go next. So the directional preference is the treatment. So if we do that neck patient's example and the patient comes back and they've done retraction, they're no better, but they've lost side movements, maybe I'll go to a lateral movement. And maybe the patient comes back and says, you know, the rotation helped a little bit, but it's still there. Well, then I'll see if rotation, more of it helped, and if not, I might go to left side bending. And the patient comes back and is like, oh, now it feels 80% better. We do more left side bending, mechanics get better, symptoms get better. I say continue with left side bending, they come back and it's 100% resolved. Well, then the left side bending is technically the treatment, but I had to go through, in that patient's case, retraction first and rotation second to get there. So of course, that line again between testing and treatment is different. And I want people to understand that just like an MRI doesn't make you better, a repeated movement test doesn't necessarily make you better. It gives me information, and if it's a mechanical problem, it will present to me the answer, the diagnostic answer, which is, oh, this is a mechanical joint derangement, and this is the movement that either makes you worse or has no effect or makes you better. But if I do repeated movement testing, say the person blew out their ACL, if I did repeated movement testing on that patient's knee and low back, possibly hip, I would expect there to be no change if the patient's symptoms and signs are due to a ligamentous injury, because the repeated movement testing would bear out that this is not a mechanical problem. And obviously, if I see somebody collapse with an ACL injury when they come into my office, the verbal history would make me think for this patient, repeated movement testing is not the test that we need. That's why the specific verbal history informs B, what baselines we take in the office, orthopedic baselines like range of motion, strength, nerve tension, and function. And it informs part 3, which is the testing that we do. Do we need to do ligamentous testing? Do we need to get an image? Or do we need primarily repeated movement testing? For over 90% of patients, the number one test I need is repeated movement testing. But for other people, we need different tests. So the take-home message is that the testing kind of becomes the treatment. And that's why people can get frustrated, but it becomes a shorter process all in all. Because say on day 1, I don't know anything about repeated movement testing, and I think that your diagnosis is a muscle strain in your hamstrings. So we embark on that protocol, and by week 6, or maybe let's say the 6th visit, you're the same. Well, if people are the same and the prognosis is that they should improve, I argue that people should always relook at the diagnosis, meaning don't just say, perhaps we have the wrong treatment or the wrong dosage. I would say go back to square one if progress is not aligning with the expected prognosis. Go back to square one and start from there again. Do we have the right diagnosis? So in that case, that person's on visit 6 and there's no effect. But if I had done repeated movement testing on day 1 and I thought it was a low back joint derangement presenting with hip extension or hamstring weakness and painful posterior thigh symptoms, and say I send the patient home with lumbar extension, they come back visit 2 the same. I send them home with lumbar side glider, they come back visit 3 the same. But then I send them home on visit 3 with lumbar flexion and rotation, they come back visit 4, significantly better. We continue with that, and then visit 5, they're discharged because lumbar flexion and rotation fixed it. So there we spend 3 or 4 visits testing, but 1 or 2 visits treating. So the overall length of care by my using repeated movement testing with patients is dramatically shortened because there's a lot of people on day 1 and day 2 where the repeated movement test that I choose to test is the actual fruitful movement. And therefore, they're only being seen in the office 1, 2, or 3 visits. And then there are more complicated cases that take longer. But repeated movement testing, I argue, is the best orthopedic test that we can use. But clinicians and patients alike need to have the patience to understand that at its core, repeated movement testing is trying to figure out the diagnosis. And the sooner we can do that, the better. And if the diagnosis reveals itself to be a mechanical joint derangement, a diagnosis that unfortunately most clinicians that work in orthopedics in the United States do not acknowledge, but if it turns out to be a mechanical problem where moving specifically in one direction or two can fix the entire disorder by getting the joint back on track, so to speak, then that repeated movement that's fruitful becomes the repeated movement treatment. And after that resolves all the signs and symptoms, there's not a phase 2 or phase 3. The problem has been resolved if all the signs are abolished and all the symptoms are abolished.